Myself, Dr. Omkar Kakare. I am an assistant professor in DY Patil Medical College. So today we are going to discuss Parkinson's disease very briefly. As we all know, this is one of a common disease which will always seen in the old age. There is a vast topic and there is a vast knowledge about the Parkinson's disease. But as a lack of time, we will just briefly discuss about Parkinson's disease. So it is a progressive nervous system disorder that affect movement. Symptoms starts gradually and sometimes starts with barely noticeable tremors in just one hand. So tremors are common, but disorder also commonly causes stiffness or slowness of the movement. So you can see in this picture, this is a typical Parkinsonian appearance. So it is a chronic progressive neurodegenerative disorder characterized by slowness in the initiation and execution of the movement, that is bradykinesia, or increased muscle tone, that we can call it as a rigidity, tremors at the wrist, and gait changes. So you can see in this picture, there is a stupid posture, there is a rigidity, forward tilt, mask-like face, reduced arm swinging, slightly flexed hip and knee, shuffling gait. So this is a typical Parkinson gait or Parkinson's. So what are the causes of Parkinson? So up till now, the exact cause of Parkinson still don't know. One of the cause we can see it as a hereditary causes. Then family history. Yes, it is of course very important to have a family history about the Parkinson's. It's so if one or more of close relatives with the disease in the family, there is a risk of getting disease is very high. Advanced age. This is one of the risk factors. So age is the risk, one of the most common risk factor for the Parkinson's. Then predominantly in the male compared to female, there is a risk of Parkinson is very high. But in female with the low estrogen levels, so usually postmenopausal women who don't use the hormone replacement therapy, they are having a high risk for getting Parkinson's. There are some medicines which also causes the risk of getting Parkinson's. So one of that is metoclopramide, which we usually use for as an anti-emetic drug, aspirin, methyl dopa, lithium, haloperidol, and chlorpromazine. Then some agriculture work exposure, environmental toxins like pesticides, herbicides, their exposure also increases the risk of getting Parkinson's, and head injury, repeated stroke, repeated trauma to the brain can cause the Parkinson's. So what happens actually in Parkinson's? So there is a degeneration of the dopaminergic producing neuron in the substantia nigra of the midbrain. So in midbrain there is a substantia nigra, and substantia nigra is having multiple types of neurons. One of that, they are the dopamine producing neurons. As due to the etiological causes, there is a degeneration of the dopaminergic neurons that leads to disruption in the normal balance between dopamine and the acetylcholine in the basal ganglia. So normally what happens is dopamine is a negative feedback mechanism. Dopamine is playing the negative feedback mechanism. As there is a decrease in the production of the dopamine, acetylcholine gets additional activation and the negative feedback is suppressed. That's why you get the tremors, rigidity, and slowness of the movement. So there is impaired extrapyramidal controlling and loss of motor control that leads to, as we said, tremor, rigidity, and akinesia. So this is a pictorial description of what I said just now. So you can see in this picture there is a normally substantia nigra. There is a dopamine producing neurons. Then acetylcholine. So this is a neuron which is having both acetylcholine and dopamine, and both of them they are combinedly managing the movement, or they are trying to do the control movement. But as you can see in the Parkinson's, the dopamine levels are reduced, so acetylcholine gets overrated and there is a disruption in the movements. So now clinical features. So you can see the rigidity is one of the clinical features. So it is defined as a resistant to the passive motion. But in Parkinson, you usually get a cogwheel rigidity, that is a jerky, ratchet-like movement, resistance to the passive movement, and muscle alternately tense and relax. So you can see in the image that there is a ratchet. You can see this cogwheel. So like a cogwheel, you get intermittently relaxation and contraction of the muscle along with the increased resistance. That is what is called as cogwheel rigidity. So this is a classical of Parkinson's. Then tremors. It is involuntary oscillation of the body. So in Parkinson's, there is usually resting tremor, and it typically disappears when patient does some activity or some voluntary activity. So usually patient will have tremors like this. That's why they named as a pin rolling tremor. Akinesia. It is absent of movement or decreased movement. So movement of freezing may occur. They are characterized by sudden break or block in the movements, or hypokinesia, that is reduced movement. Then postural instability. It is very common in Parkinson's, and it may describe being unable to stop themselves from going forward or going backward. That is what is the postural instability. So just to summarize the symptoms of the Parkinson's or clinical features, The most important thing is Parkinson is a diagnosis made usually in the clinical basis. Usually it starts from the one hand or the one limb and then it progresses to all over the body. So usually it presents with the tremor, akinesia, or rigidity and postural instability. Then there are some other associated features of the Parkinson's like hypomimia. What is hypomimia? Hypomimia is mask-like face. As you can see now, I am talking, I am having some facial expression on my face, but Parkinson patient will have no facial expression on his face. Then there is a drooling of saliva, low volume speech, dysarthria, problems with the swallowing, long time to complete the task, stiff face in the advanced Parkinson's, altered cognitive functions. Sometimes it can cause dementia and disorders of intellectual functions. So these are some associated functions, presentations of the Parkinson's. Now, what are the complications? This includes motor symptoms like dyskinesia, dementia, depression, hallucinations, psychosis, dysphagia, malnutrition, aspiration pneumonia, orthosteric hypotension, and risk of fall. So these all are the complications of advanced stage of Parkinson. The moment patient develops symptoms of rigidity, tremor, akinesia, and postural instability, these complications can be usually seen. So diagnosis, as we already discussed, it is based on clinical features. CT or MRI just to rule out the other secondary causes. Sometimes we also do PET scan to evaluate the levodopa uptake and conversion of dopamine to corpus striatum. Now we will discuss shortly about the treatment of the Parkinson. So as there is a degeneration of dopaminergic neuron, we have to supplement dopamine from outside. So levodopa is one of the mainstay of the treatment. But what happens is levodopa is easily converted in the peripheral circulation. So to increase the levodopa levels in the body, we add a levodopa with the carbidopa, which is a peripheral decarboxylate inhibitor. So that's why it increases the availability of the levodopa inside the brain. Then there are some dopamine receptor agonists. These are the drugs that activates or stimulate the dopamine receptors. So like ergot derivatives, that is bromocriptine and pergolide. But nowadays we don't prefer ergot derivative because of its side effect profile. But yes, we use non-ergot derivative profiles like pramiprazole and propionyl. Then there is monoamine dioxidase inhibitors, that is MAO inhibitor. So usually it blocks the breakdown of dopamine and they're used primarily to treat the motor fluctuation associated with the levodopa treatment. So most commonly drugs used, they are selegiline and rosaline. So MAO inhibitors, they are add-on therapy to the levodopa. In this, they just increase the life of dopamine by reducing the breakdown of the dopamine. So this is a list of drugs. I will just shortly revise the drugs. So levodopa, as we already discussed, pramiprazole we discussed just now. Then there is a dopamine agonist like amantadine. They are dopamine agonists. They increase the dopamine activity. Then some anticholinergic drugs like triazepam we use just to reduce the symptoms like tremors, rigidity. Then some antihistaminic drugs, MAO inhibitors and COMAT inhibitors like entacapone, telcapone. So these COMAT inhibitors, they block the COMAT and slow down the breakdown of the levodopa. This prolongs the action of levodopa. So you can see MAO inhibitors, COMAT inhibitors, they are all the add-on therapy to the Parkinson. So basically, if we start the treatment of Parkinson or if we discuss the treatment of Parkinson, you have to start unless otherwise proved with the levodopa and carbidopa combination. Then additionally, you can go for pramiprazole, amantadine, triazepam as per the symptoms, and MAO inhibitors and COMAT, they are the additional therapy to the Parkinson. Surgery is optionally only when medicine doesn't make symptom better. So thalamectomy can be done. It is a surgical procedure in which an opening is made into the thalamus to improve the overall brain function. Then deep brain stimulation. So there is a, you can see this image. So there is a one stimulator which is situated inside the thalamus. So it can be used to treat the tremors and uncontrolled movements of the Parkinson's. So electrode is surgically placed inside the brain and it stimulates like a pacemaker from the externally. Then physiotherapy. A combined approach of physical therapy and pharmacological intervention plays a key role in management of the patient. So physical therapists should be fully aware of medications the patient is taking and potential adverse effect. So optimal performance can be expected at peak doses. So whereas worsening performance is associated with the end of dose cycle. So why I am discussing physiotherapy? So as we already discussed, it is a neurodegenerative disease. So there is a no cure for Parkinson's. So what you can do is just control the progression and control the symptoms so that you can improve the quality of life of the patient. So in this, Along with the medicines, we also need help of physiotherapy and nursing staff. So treating Parkinson is a holistic approach job. It is not a single person job. So that's why physiotherapist should understand which drug he is taking, what are the effects and side effects of the drug. Also, in that they have to see for the exercise training, strength training, balance training, correcting the eating impairments and verbal skills. Then nursing, as we discussed, the nursing approach is very important. So nursing, they should first assess, make the assessment to obtain, so that they should take the history, symptoms, effects, functionality, mobility, feeding, communication. Also, they have to assess the cerebral function, motor function. They observe the gait, performance of the activity. They should see for the speech, signs of depression, and family support. So, to treat the Parkinson, we need to have a holistic approach. Just to revise the Parkinson, it is a disease of neurodegeneration, old age disease, in which you get dopamine neurons which are degenerate, so low level of the dopamine, which causes increase in the acetylcholine activity, and there is a tremor, rigidity, akinesia or bradykinesia, and postural instability. So it is mainly diagnosis of clinical based diagnosis. You can treat Parkinson with the levodopa, carbidopa, pramiprazole, then comatin, MAO inhibitors, and as we last to again to say that Parkinson is a disease which is treated by holistic approach, teamwork. So in this you have to have one physician along with the physiotherapist, nursing care, and lot of family support. So this is all about Parkinson's. Thank you so much.